Hello and welcome to Clinical Society meeting. Today in the CSM, the first presentation is from Division of Pediatric Nephrology, Department of Pediatrics. And it will be moderated by Dr. Abhishek Abhinay. I request Dr. Abhishek to initiate it. Over to Dr. Abhishek.
Very good morning to all of you. Today, interesting case presentation from the Division of Pediatric Nephrology, Department of Pediatrics. Dr. Rishabh will present the case. He is a fellow in the Pediatric Nephrology. Over to you, Dr. Rishabh.
Very warm good morning to everyone. So the patient who presented to us was a newborn male baby, resident of Jaunpur, who presented to the pediatric emergency on day 3 of life with complaints of breathing difficulty since birth and bleeding from urethral meatus for 1 day. The baby was born at term at 38 weeks of gestation to a primary gravida mother with a birth weight of 2.8 kg through an emergency LSCS in view of fetal distress. The baby delivered through meconium stained liquor, but the baby cried immediately and there was no need of any delivery room resuscitation. The baby developed respiratory distress soon after birth, for which the baby was admitted to NICU at a private hospital where the baby received oxygen by nasal cannula, IV fluids, and antibiotics. On day 3 of life, baby also had bleeding from urethral meatus, and the baby was thus referred to BHU for further management. There was no history of fever, bluish discoloration of body, any feeding difficulties, lethargy, vomiting or diarrhea, no history of decreased urine output, no history of swelling over the body, and no history of abdominal distension. Antenatal history, it was a booked pregnancy which was mostly uneventful. There was no history of any drug intake in mother, no history of any gestational diabetes mellitus or hypertension in the mother. The mother underwent 3 antenatal ultrasound scans, all of which were reported normal, and there was no evidence of oligohydramnios in any of those. Family history, the baby was the firstborn male child, product of a non-consanguineous marriage, and there was no history of any similar complaints in the 3 generations. The family belonged to upper middle class and the baby was unimmunized at that time. On examination, the baby was conscious, active and alert with a temperature of 36.5 degrees Celsius, heart rate of 122 per minute. The baby had mild tachypnea with with a respiratory rate of 62 per minute. The capillary refilling time was less than 3 seconds. The peripheries were warm. The peripheral pulses were palpable and with good volume. The baby had a saturation of 89% on room air and 99% on oxygen at 2 liter per minute with nasal prongs. As far as the anthropometry is concerned, the weight, length, and the head circumference of the baby were between 10th to 50th centile according to the Fenton's chart. On systemic examination, respiratory system, nasal flaring was present. There were no retractions. Bilateral air entry was present, and there were no adventitious sounds. The CVS examination was normal. On per abdomen, the abdomen was normal in shape with no distension, no organomegaly, non-tender. Blood clot was present at the urethral meatus. The CNS examination was normal. So at this point, the clinical diagnosis was a single-term male baby with appropriate for gestational age, delivered by emergency LSCS with respiratory distress since birth and bleeding from urethral meatus. On asking the history, the parents told that outside where the baby was admitted, there was a history of attempted catheterization on day 3 of life, following which the baby developed this bleeding from the urethral meatus. As far as the respiratory distress part was concerned, we kept the possibility of meconium aspiration syndrome first because the baby was delivered through meconium stained liquor. Second was transient tachypnea of newborn, and third possibility was sepsis. The preliminary investigations were sent and the baby was started on oxygen via nasal prongs, IV fluid. Antibiotics were started as piperacillin tazobactam and injection vitamin K was given for bleeding. These were the investigations that were done outside. So here we can see that the baby had thrombocytopenia on day 1 and day 3 of life outside, and there was azotemia. The urea and creatinine was raised. We repeated the investigation on day 3 of life at our center, and again we found that there was thrombocytopenia with a platelet count of 47,000. The urea was 94.4 and creatinine was 4.1. The LFTs were normal. Coagulation profile was also normal. The blood gas showed a metabolic acidosis with a pH of 7.25 and a bicarb of 16.9. Urine analysis was done. It was reddish in color with a pH of 7.5. Oxalate crystals were present. RBCs were more than 500 per high power field. Pus cells were present and nitrite was positive. We ordered an ultrasound abdomen for the baby, which showed normal sized kidneys with normal shape and location. However, there were hyperechoic foci in the tip of bilateral medullary pyramid, suggestive of medullary hypercalcinosis with an underlying possibility of renal papillary necrosis. A thyroid screen was done, which was normal. Urine calcium creatinine ratio was done based on the ultrasound findings, which was normal for the patient's age. So at this point, as far as the etiology was concerned, we kept these 4 possibilities. First being birth asphyxia, which explains the patient's AKI acidosis, the renal papillary necrosis on ultrasound, and thrombocytopenia. However, the points that were against was that there was no history per se of baby requiring any resuscitation or any birth asphyxia. And when the baby presented to us, there was no neurological manifestation. The second possibility was congenital anomalies of the kidneys and the urinary tract. Again, the points that were favoring were AKI, the age of the patient, and hematuria. However, we did not find any such findings on the ultrasound. Third possibility was distal RTA, which was favored by normal and iron gap metabolic acidosis and a urinary pH of more than 5.5 and nephrocalcinosis, but a strong point against was AKI. The fourth possibility was primary hyperoxaluria, which explains the AKI and nephrocalcinosis. However, we kept it down low as a possibility because it is a very rare defect with an incidence of 1 in 1.2 lakh patients. So here the diagnosis per se was singleton term baby appropriate for gestational age with respiratory distress since birth with acute kidney injury with metabolic acidosis and medullary hypercalcinosis. So here the plan was first to manage the thrombocytopenia and the AKI of the patient. So 2 units of platelets were transfused and a peritoneal dialysis was initiated for the baby on day 5 of life. A peritoneal catheter was inserted in the infraumbilical region, and these were the peritoneal dialysis settings that we kept. The reservoir volume of 20 ml per kg, dwell volume of 10 ml per kg, and a cycle time of 60 minutes. This was the monitoring through the dialysis. The baby underwent 72 cycles of peritoneal dialysis, and we can see there was a significant decline in the urea and creatinine from the beginning. That by the end of 72 cycles, the urea dropped down to 35 and creatinine became 1.9. Rest of the parameters were almost normal throughout. This is the graphical representation of the same, showing a significant decline in the urea and creatinine of the patient. We repeated the investigations again on day 10 and day 12 of life. On day 12 of life, the patient's urea further declined to 16 and creatinine was 1.4. Sodium was 136, potassium was 4.6. At this, the patient was planned to be discharged. The advice which was given on discharge was to exclusively breastfeed the baby. Vitamin D was supplemented, and the parents was advised to get the baby immunized as per the schedule. And genetic study was sent because we were still thinking of possibilities of RTA and primary hyperoxaluria. The baby followed up first time at 1.5 months of age. The investigations were repeated, and there was in the investigation there was anemia which was seen with an HB of 7.4. However, the retic count was normal, and the peripheral blood film was also normocytic to microcytic with hypochromia. The urea and creatinine had further improved. The blood gas was almost normal with the bicarb slightly on the lower side. The urine analysis again showed pH of 7. The rest of it was almost normal. Also, we had an IPTS done because it is a known cause of hypercalcinosis, which was normal, and an LDH was done in view of anemia, but that was also normal for the patient's age. We had also received the genetic report by then, which showed that there was a mutation in the SLC4A1 gene. This has been reported before. It is a likely pathogenic variant, and it is associated with distal renal tubular acidosis with hemolytic anemia and inherited in an autosomal recessive fashion. So now the final diagnosis of the patient was a singleton baby, term appropriate for gestational age, with respiratory distress since birth with settled, acute kidney injury that was resolved, with distal RTA with hemolytic anemia. Talking about RTA, it is a group of transport defects affecting the tubules. It is mainly of 3 types. The type 2 is the one with the defect in the proximal tubule. There is defective resorption of bicarb. The type 1 is affects the distal tubule, and there is a defect in the distal secretion of protons, and a type 3 which has combined type 1 and type 2 faults. The patient usually presents with hyperchloremic normal and iron gap metabolic acidosis. This is a simplified approach when we find normal and iron gap metabolic acidosis in the patient, and we have ruled out the extra renal causes of bicarb. So we go for urinary pH, and the urinary pH, if it is more than 6.5, then it shows that there's a significant problem with the acidification of urine and points towards distal RTA. Talking about the mutations, so in this figure, the cell that is shown is an alpha intercalated cells. There are 2 pumps mainly on this. On the luminal surface, there is an H plus ATPase pump, and on the basolateral surface, there is an anion exchanger pump. So these are the there are mutations in these pumps that are associated with primary distal RTA. The mutations in the H plus ATPase pump, these are more common and always inherited in an autosomal recessive fashion. And the mutations in these causes RTA, which presents early and is severe. However, the mutations which are present in the anion exchanger pump, they can be inherited in either autosomal recessive or dominant form. But these mutations, usually the disease presents late, and it is of less severe variety. The mutation that we found in our patient affected this anion exchanger 1 pump. So like I was saying, so these are the common mutations are these ATP6V1B1 and ATP6V0A4 mutations, which affect the H plus ATPase pump, which cause early onset and severe form of RTA. And SLC4A1, it is a rare mutation which affects the chloride bicarb anion exchanger pump. And this pump is present along with alpha intercalated cell. It is also present on the erythrocyte membrane, which explains that why these patients have associated hemolytic anemia. However, the distal RTA in this mutation is supposed to be of milder form. Currently, the patient is on exclusively breastfeeds. Folic acid has been added for anemia. Vitamin D is being supplemented still. Soda bicarb has been added to manage the acidosis. Genetic counseling has been done, and the patient is planned to be followed up in pediatric nephrology and genetics clinic.
Thank you, Rishabh. Now moving on the discussion part. So why we have selected this case for the CSM presentation? Because RTA is a rare defect. And in our case, we found there is a rarest mutations. And most importantly, the rarest presentation. And by the timely initiation of peritoneal dialysis, it's a life-saving and there is full recovery of renal function and we can able to save the units. So prevalence is not very well known because in India, very less information is available regarding the prevalence, clinical course and outcome. There is single study done by the Kiran et al. Out of total RTA, 44% are due to this part of the distal RTA. And compared to this, in Western world, the distal RTA prevalence is 0.46 per 10,000, of which 22% accompanied by distal RTA. This is a recent data published from the UK. So even single gene mutation can lead to tubulopathy. So till now, approximately 63 causal genes had to be identified till now. And out of these, these 3 genes are mainly responsible for the distal RTA. Out of these, SCLA4A1 gene is rarest cause of the mutations. So why rare presentation? This is seldom occurrence of neonate present with RTA, especially distal RTA has never been known to be presenting with acute kidney energy in pediatric age, which requires peritoneal dialysis. So how to explain AKI in this case? Why there is occurrence of AKI? So there is theoretical possibility here: dehydration secondary to acidosis leading to prerenal AKI, or obstructive nephrolithiasis causing postrenal AKI. As in this case there is nephrocalcinosis is there, but as such obstructive cause of AKI in case newborn is rare, less than even 3%. So why, as per the genetic report, we got the distal RTA with hemolytic anemia. So why this child not having hemolytic anemia? So all the feature not be present at the same time. It can develop during later of life or in the follow-up. So there are some review of literature. There is this type of mutation has been first reported by the Sakumbar et al. In 2010. In their age of presentation is 6 years and 16 months. Our presentation is different. One of the presented with jaundice, fractures, and other kids presented with hypotonia and anemia. There is a study done by Moret TA and Kedar PS from the ICMR, National Institute of Immunohematology, KM Hospital, Mumbai, which did genotypic analysis of SLCA4 mutation from the 16 individual of the 12 family member who is clinically diagnosed distal RTA with hemolytic anemia. All these patients got their same mutation or same mutation with hemolytic anemia, but occurrence of this mutation finding is minimum age of this is 8 months. In that family, there is history of familial occurrence. So I want to say this mutation as such rare, but in this there is association of hemolytic anemia. But in this child there is not at present, but it can develop later on life. So why early diagnosis is important? So affected child may have multi-system involvement and life-threatening complication later on. So high degree of clinical suspicions. With the help of genetic study, we made the diagnosis early so that we can pick associated defect earlier without developing the disease. Patient with distal RTA, when treated earlier, we can't able to prevent but can delay the development of CKD. So short stature can be ameliorated by early diagnosis and proper treatments. So what are the long-term outcome? A recent cohort study, including 340 patients done by Lopez Gracia et al. He followed up to 11 years. In this study, there are two parts, including pediatric and adult parts also. On pediatric symptoms what did so in pediatric age group, most of the symptoms occurs during infancy or early childhood, and serum potassium is low or lower limit of normal limits. Most of the patients have medullary nephrocalcinosis, as in our case, but patients rarely present with hemolytic anemia, or there is occurrence of nephrolithiasis also there in around 40% cases, and prevalence of chronic kidney disease stage more than 2 in children is 35% and adult is more than 80%. So we can't prevent chronic CKD in case long term in RTA, but can delay the progression. Adult height was slightly below the average. So how to follow these kids? So initially strict follow-up is required initially for 6 monthly for 2 years. Finally, I especially look for the anthropometric measurement such as weight, height, and biochemical parameters such as monitoring of bicarbonate concentration, by regular monitoring of EGFR, hearing assessment, and ultrasound for early basis. Especially looking for the development other features, like in this case the features suggestive of hemolytic anemia. So it can be developed in later on life, or other features. Planning and counseling of parents for the genetic state, because this is autosomal recessive variants, it can occurs in every pregnancy, chances of 25%. So this is the first kit. So we can offer the genetic screening methods for the next pregnancy. In these kits, generally lifelong follow-up is required. So my take-home message is the low prevalence, phenotypic heterogeneity, and positive clinical and biological data limit our knowledge of the renal tubular acidosis. So we need high degree of clinical suspicious, definite role of genetic study to know the genotype so that we can start timely management and able to minimize long-term complication and improve quality of life. As in our case, suppose we didn't send the genetics, we don't know about the genotypes. So this baby can came after 1 or 2 years of it with multiple severe symptoms like acidosis and failure to thrive, etc. Last but not the least, peritoneal diagnosis is life-saving in a critical ill neonate and older infant, and it is good recovery for kidney function, and it should be started promptly whenever indicated for survival of these infants with AKI, especially when CRRT is not affordable or available. There are recent data from our center published in which there are 52 infants underwent a peritoneal dialysis, out of which 24 were newborn and 28 were postnatal age group. And kidney function were assessed at the admission, discharge, and the 3 months follow-up. There was significant recovery of kidney function occurred at the discharge, and cases had a normal parameter at the 3 months, almost 3 months. So this is the same child at 1.5 month follow-up. Thank you.
Thank you, Dr. Abhishek. I think your presentation was completed before time. 2 minutes are still left, and very good presentation. We have questions in the chat. So let's take a question from the chat. I have some queries like the peritoneal dialysis. This question is for the resident who presented the case. The peritoneal dialysis, when we prescribe in a children, how it differs from the adult?
Sir, so in neonate, usually we prefer it in newborn, in small babies, because it is easier to do peritoneal dialysis. The option of hemodialysis is still difficult to perform in infants and young children. Obviously, we have to take into account that it has to be the cycle. We have to take care of the cycle time and the dwell volume. It all has to be according to the weight of the baby, and we have to obviously there are risk of complications that are always there, so they need to be taken care of.
So it is more body surface area we take into consideration in while prescribing the peritoneal dialysis, different components, the solutions and other things.
Based on the body weight of the baby.
Okay.
So we usually, yes, sir, the reservoir is usually made in a range of 20 to 30 ml per kg, and the dwell volume that we keep, that is kept around 10 to 15 ml per kg.
Any other difference?
in peritoneal dialysis prescription, there it depend upon the bed. Or initially in case of newborn, there are lower volume. Newborn is a lower capacity, and it's depend on the clinical scenario also. Suppose baby having tachypnea or respiratory compromise, so you can take lower volume. This normally we take reservoir made by 10 to 12 ml per kg. So we can made by 12 ml, or cycles is lower per kg lower we can lower.
I request Professor Jayaprakash Ojha, sir. Sir, you can unmute and give your comments. Okay, I request Professor Ashok Chaudhary, sir. Sir, you can unmute and give your comments.
Well, I have no any specific questions. It was a nice presentation. I would say that this was a more kind of incidental diagnosis because the baby had entirely different kind of presentation, slight tachypnea. And most likely he was referred to BHU because outside they tried to catheterize, and then there was some trauma and bleeding, and probably that practitioner panicked and they referred the baby to BHU. And then we did blood gases and we found there was normal anion metabolic acidosis. But the clue for the diagnosis came from radiology, where they did ultrasound and they suspected nephrocalcinosis. If ultrasound was reported as normal, probably we would not have pursued further as per the genetic testing is concerned. So that's my otherwise nice presentation by the unit. Thank you.
Okay, so I think there is a question from Professor S.K. Singh, sir. When to suspect RTA in neonates?
Sir, a newborn, if there is, as in this case, there is nephrocalcinosis, urinary pH is more than.
Dr. Abhishek, I think let the resident first answer. If he will not able to answer, then you can add.
So, first of all, if the baby, he presents with a normal and anger metabolic acidosis, so we should always keep RT as a possibility. Once we have ruled out the other causes of acidosis, like the GI losses and all. And after that, we can get a urine, as the protocol says, we get a urine pH done, which gives us a clue about whether it is a proximal or a distal RTA. So if there is an ability to acidify the urine, and the urine pH is always more than 5, so we suspect that the patient has distal RTA. Along with that, there might be electrolyte imbalances in the patient. So yeah, that gives the.
I request Professor S.K. Singh, sir. Sir, you can unmute, and if you want to add something, you can add. Professor S.K. Singh, sir.
Yeah.
Yes,
Thank you, Abhishek. Thank you. The idea of asking this question, what are the clinical conditions where you suspect? Like in this case, nephrocalcinosis was one, which is not very common to see nephrocalcinosis and distal RTA associated SLC4A mutation. But what are the common clinical indicators of renal tubular acidosis in neonates other than the nephrocalcinosis? Nephrocalcinosis is not that common also. Luckily, in this case, it was there. Therefore, you could make a diagnosis of SLC4A mutation. But it is not that common thing to occur in neonate. It may occur with subsequently in the later life, even if it is a distal RTA. So what are the other clinical conditions which alarm you to suspect renal tubular acidosis that we should learn from the case? The second thing, that SLCA4 mutation, how common is to see the distal tubular acidosis in persons having this mutation? All the patients with this mutation may not manifest with distal renal tubular acidosis. So how common is to see? What you said is the clinical anecdotes, cases where there have been association of the mutation as well as the functional defect in the tubules. But how common is this mutation to present with renal tubular acidosis? That should also be learned from the case.
So answering the first question, sir, so we should always suspect RTA if the patient has acidotic breathing or if the patient presents as failure to thrive and inability to weight gain. Along with it is very difficult because the features, clinical features, most of RTA can also overlap with with more common things like sepsis. The patient might also present with lethargy, vomiting, inability to feed properly. So whenever we have such a presentation and we have ruled out the common causes, we should always think of having an other underlying cause like RTA. As far as the second question is concerned, so this there's not much data as to how much how many percentage of these patients with these mutations have distal RTA. As a case report which is shown, so till now there are 16 in India there are 16 cases which belong to 12 families who had this mutation, and all the patients they presented they were diagnosed to have hemolytic anemia first, and then they got the investigations done, and the patient also had failure to thrive, and also then we suspected the patient also had RTA.
Sir, distal nephrocalcinosis is generally presented by the distal RTA, sir. But as your first concern, sir, answer to first question, sir, as per RTA is concerned, it can present by like proximal defect. It can failure to gain, or repeated fracture, or rickets, or like acidosis or acidic bleeding. Not failure to these are the presentation. As per mutation is concerned, in your second question, sir, it can occur by the two way, in autosomal recessive or autosomal dominant variant. In autosomal dominant variety, it is a milder form. It generally present in adult on adolescent age group. There is no non-renal manifestation. Or in this variety of mutation, like autosomal recessive SLC-A4 mutations, in this there is chances of other, as per the reports, sir. There is some reported that child went Burkup for the hemolytic anemia, and she found their association of RTA also. So what does it indicate? It is a milder form, sometimes without asymptomatic, or pH within normal limit, bicarb in normal limit. So it's required treatment in milder form. So there is not much data regarding this mutation, sir.
Okay, Dr. Abhishek, in the urine examination, there was oxalate crystals were present. Any significance of it?
That's why primary be suspected on the primary hyperoxaluria, but there is no clear-cut reason got why there is oxalate crystal, because it's still persisting. But there is in distal RTA, especially in acquired variety, there is association of primary oxalate crystal, but there is no such literature was found.
Okay. I request Professor Siven Singh sir is sitting there. I request sir, if you want to add something or give your comments on the presentation.
Okay, things have already been discussed.
Sir, if you come closer to the mic, then it will be much better.
But it usually the diagnostic dilemma is there when to suspect distal RTA. Presentation is very vague, as already told. Children with poor weight gain, failure to thrive, or usually bony presentation is there when we suspect and go for ABG and ultrasound. ABG is diagnostic, and ultrasound we can find nephrocalcinosis. This is the usual clinical presentation when we suspect. Otherwise, in other forms, medullary nephrocalcinosis is there, then we can work up this patient, but there is a clinical high risk of clinical suspicion is required to diagnose distal RTA, because presentation is not very typical. Clinical presentation is not very typical.
Okay. Okay. Dr. Abhishek, there is one question from Professor Rahul Khanna, sir.
Yes, sir.
You can see in the chat.
Indication of catheter. Sir, this catheterization has been done by outside, probably due to by looking the urea creatinine value, sir, due to AKI. This catheterization has been done by outside.
Okay. So I request Honorable Director, sir, to give his comment on the presentation.
Thank you. It's really very nice presentation. well prepared. Even the resident was very confident. The differential diagnosis, positive and negative, why that was really well prepared. It should be like that only. And ultimately, the outcome is very good. Though we discuss the cases, here the patient, the neonate child, they could save the child, and this is wonderful. Timely diagnosis, that's more important. So even presentation is very nice, good discussion thereof. Congratulations to the pediatric nephrology unit for doing very good job, and all the pediatric unit. As always, pediatrics, their presentations are always very good, whether it is pediatric nephrology or other units. They take lot of pains to prepare, I think, good presentation. Thank you.
Thank you, sir. So moving to the second presentation, it's from Department of Nephrology. I request Professor Sivan Singh, sir, to initiate the second presentation. Over to you, sir.
Morning, everyone. Today's case in nephrology is a case of anasarca with neuropathy with some diagnostic dilemmas, which will be discussed by our senior resident, Dr. Akshay, to present the case.
Morning, teachers and colleagues. I'm presenting a case of nephrotic syndrome with neuropathy. We have a 28-year-old female patient who came to Sir Sundarlal Hospital with chief complaints of intermittent abdominal pain for 2.5 months, generalized body swelling for 2 months, and progressive weakness with pain and tingling sensation in all 4 limbs since 1.5 months. Patient's complaint started as abdominal pain 2.5 months back, which was intermittent, diffuse, mild to moderate in intensity, not aggravated or relieved by food, and was associated with semi-solid stools with frequency of 1 to 2 times per day, and was not associated with blood in stool or any color change. 2 months back, she developed swelling all over the body, which was first noticed around eye, followed by lower limbs, and then progressed to all over the body. 1.5 months ago, she noticed progressive weakness in bilateral lower limbs, which started with difficulty in getting up from squatting position, followed by slippage of slipper without awareness. 7 days from the onset of lower limb weakness, she noticed weakness in bilateral upper limb, which first started with weakness in lifting the arm above the head, followed by weakness in breaking rotis and chapatis with hand. This weakness was bilaterally symmetrical and she had looseness all over the limbs. Over the next 1.5 months, this weakness progressed such that she was bedridden with only mild sideways movement of the limb in bed. Patient, along with the weakness, patient had also complaints of tingling sensation and severe burning pain all over the upper limb, severe burning pain on both upper limb and lower limb up to the level of elbow and knee respectively. There was no history of gallbladder involvement, twitching of muscle or thinning of muscle, or any muscle pain or any bend-like sensation. There was no history suggestive of any cranial nerve involvement, any swallowing difficulty or any sweet difficulty. There was no history of any difficulty in lifting the neck. There is no history of chest pain, shortness of breath, fever, altered sensorium, nausea, vomiting. There was no history of decreased urine output, abnormal urinary discoloration, skin rashes, joint pain, photosensitivity, or oral or nasal ulcers. No history suggestive of any toxin exposure. Past history, the patient has no known comorbidities like diabetes, hypertension, tuberculosis, jaundice, or any history of blood transfusion. There is no history of similar complaints in the past. Personally, patient is mixed in diet with no addiction, sleep and appetite were normal. Patient was normally menstruating, married female with 3 children, all were full-term normal delivery. History of 1 spontaneous abortion at 1.5 months of gestation before the first child. There is no significant family history. To summarize the history, we have a 28-year-old female without any prior comorbidity, now presenting with intermittent abdominal pain and anasarca for 2.5 months, which is followed by subacute, painful, progressive, bilaterally symmetrical lower motor neuron type of weakness in both lower limbs, followed by upper limbs, which is more proximal than distal and associated with tingling sensation and severe pain without any gallbladder involvement, neck weakness, bulbar, or any other systemic features. Moving to clinical examination, the patient was afebrile at presentation, pulse was 72 per minute, right radial, respiratory rate 18 per minute, blood pressure was normal, 120 by 80 millimeter of mercury, There was presence of generalized body edema, and there was no pallor, lymph node enlargement, icterus, cyanosis, or clubbing. On examining CNS, the patient was well oriented to time, place, and person. GCS was full. On examining motor system, the bulk was found to be symmetrical bilateral with normal. Tone was reduced in bilateral upper limb and lower limb. The power at shoulder joint in all muscles as shoulder joint was reduced to 3/5 bilaterally. At elbow, 4 minus bilaterally, and at wrist was 4/5. Hand grip was weakened by 50% on both sides. There was pronounced weakness in hip also. The power of muscles at hip joint was 3/5 bilaterally, at knee 3/5 bilaterally, and at ankle 4/5. All the reflexes were absent. The plantars were bilateral downgoing. Sensory examination was done, which was found to be pain, touch, and temperature, as well as joint position and vibration sensation was impaired bilaterally up to knee and up to elbow. On respiratory system examination, there was no added sounds, although there was decreased bilateral air entry in infrascapular region. Cardiovascular examination was normal, and on abdominal examination, there was no tenderness. Shifting dullness was elicited. Urine examination was done with suggestive of protein +4, that is marked proteinuria, with no hematuria and no cast and crystals. So provisional diagnosis based on history and examination was kept as nephrotic syndrome, which was considered secondary to systemic illness, with sensory motor neuropathy and chronic abdominal pain. The cause was kept as vasculitis as the first differential diagnosis, owing to the age of the patient, gender, and the multisystem involvement, which could be either immune complex mediated or quasi-immune. With second differential was kept as amyloidosis, owing to neuropathy and nephrotic syndrome. Patient was investigated. CBC was found to normal.
Just come to the differential diagnosis slide.
Yes, sir.
Yes.
Sir.
So this patient was having abdominal pain for a long duration, right?
Yes, sir.
So what was the cause for abdominal pain you kept?
Sir, based on the clinical examination, we couldn't locate the exact site, exact etiology of the abdominal pain, as there was no abdominal tenderness elicited. Might be due to the presence of mild to moderate amount of ascites, as evident by shifting illness. So, sir, we couldn't exact pinpoint the etiology of chronic abdominal pain based on the examination, sir. Sir,
Okay.
it was investigated later on and found to have, sir, some ileocecal inflammation, sir.
Okay. Okay. So the differential diagnosis, the first the cause you have kept as a vasculitis, right?
Yes, sir.
Why vasculitis?
Sir, owing the patient was 28-year-old, gender was female, and sir, nephrotic syndrome was there, which was definite on clinical examination. Sir, cause second, a patient with nephrotic syndrome and neuropathy, we are bound to look some autoimmune pathology. So, sir, the first differential we found was vasculitis, sir.
So this patient was not having any skin manifestation?
Sir, there was no skin rashes. There was no history of any skin manifestation, sir.
Okay. And what about the amyloidosis?
Sir, amyloidosis which kept was in view with nephrotic syndrome is a most common manifestation in amyloidosis. Along with the nerve involvement is also documented in amyloidosis, sir. So that was we tried to make a single diagnosis which could explain all the symptoms of the patient. So amyloidosis kept as the second diagnosis, sir.
Okay. If any adult patient coming with nephrotic syndrome, what is the most common cause?
Sir, according to age, if the patient is above 50 years of age, membranous nephropathy will be our first differential diagnosis. That can be primary or either secondary to any neoplasm or malignant etiology. And sir, in this age, patient can present with FSGS, membranous nephropathy as well. At a younger adults onset, MCD can also be there, sir.
Okay. So the inputs.
Can I give a comment, please? See, I got a
Oja sir, I think there is some interruption. There is some voice issue from your end. Some echo sound is coming. So we will take your comments after this, like when we'll start the discussion. You can proceed further.
RFT was within normal limits, LFT was within normal limits, electrolytes were normal. The positive findings in investigation was severe hypoalbuminemia with dyslipidemia. Her RBS was normal, thyroid profile and B12 was normal, and her viral markers were negative. We quantified the 24-year neuroprotein that was found to have 7.5 gram in nephrotic range. Her ECG and echo was normal. Our ultrasound was done, which showed bilateral normal size kidney with maintained corticomedullary differentiation, and there was presence of ascites and bilateral pleural effusion. Our autoimmune markers were sent as our first differential was autoimmune pathology, which came back negative, as ANA was negative, dsDNA negative, and all other autoantibodies profile were negative. I would like to call Pathak sir if they can comment on NCV report, sir.
Thank you. So this was a case going, it was technically SIDP, subacute inflammatory demyelinating polyneuropathy. We say demyelinating because the patient had proximal weakness clinically more than the distal. Although it can be taken with a pinch of salt, and CV was done on the neuropathy pattern, neuropathy protocol, and you can see all the sensory and motor nerves, including F waves, they were non-recordable. Go ahead.
Thank you, sir. CSF examination was done, which showed no albuminocytological dissociation. Cell was 4 and protein was normal. Sugar was also normal. Her MRI brain with whole span screening was also advised, which found to be normal. Her contrast abdomen was done to rule, which was suggestive of thickness in ascending colon, which is up to 10 mm Hg with moderate ascites, bilateral moderate pleural effusion, causing collapse of bilateral lower lobes, and there was presence of mild pericardial effusion also. Colonoscopy was done, which showed multiple ulcers of variable size with fibrinous base in terminal ileum, with a large transverse ulcer of 2 by 3 centimeter size in ascending colon with surrounding mucosal erythema and edema. There was thickened mucosal fold in ascending colon. Biopsy was done from the same areas, and it showed that there was chronic active colitis, and the probable etiology was query infective, query inflammatory. To rule out infective etiology, stool investigations were sent, which were normal, which leads to which were unremarkable. I would like to call Ojas Gupta sir to comment on renal biopsy pathology.
Do we have the colonoscopy images?
Sorry.
The colonoscopy images are there?
No, sir. Colonoscopy images are not available, unfortunately, sir.
Okay.
So in this renal biopsy, there was a total of 26 glomeruli. This is one of the light microscopy picture of 40x magnification, which is PS stain slide. It is showing one of the representative glomeruli. So all the glomerulus were showing diffuse thickening of the capillary wall, and they were enlarged. Among the total glomeruli, 4 glomeruli show segmental sclerosis with interstitial fibrosis and tubular atrophy of 10%. There was absence of any globular sclerosed, and there was absence of any crescents or any features of vasculitis. No amyloid deposits were present. Arteries and arterioles were unremarkable. On direct immunofluorescence, it showed full house pattern with extraglomerular positivity in the tubular basement membrane. IHC was done to exclude the possibility of primary membranous nephropathy, and PLA2R antibody, thrombospondin, and SEMA3B and exostocin, they were all negative. Now coming, a transmission electron microscopy was done, and to show the pathological part, there are 2 images. This is a normal image of a transmission electron microscopy of a glomerulus. So this is part of the glomerular capillary tuft. Here we can appreciate normally this is the glomerular basement membrane, and these are the podocyte foot processes. So they form slit-like areas through which the membrane filtration happens. And this is the endothelial site where capillary endothelial cell fenestrations are present. So a normal glomerular basement membrane thickness in a female patient is from 270 to 320 nanometer. Now this is the picture of a patient which is taken at 500 nanometer. So here the GBM thickening, we can see that there is thickening of the glomerular basement membrane. The foot processes which were used to be like slit like, they are all effaced. So they have got the foot processes got effaced. So that is the reason of heavy proteinuria going on. In addition, there is a subepithelial deposits, submesangial deposits, and there are presence of few tubular reticular inclusions in the endothelial cell cytoplasm. So taking into these account the presence of extraglomerular positivity on DIF, presence of tubular reticular inclusion, presence of a full house pattern on the DIF, possibility of secondary membranous nephropathy is there.
Dr. Ojas, the TEM was done at our place?
No, sir, it was done at outside actually.
Okay.
Final impression from the renal biopsy was secondary membranous nephropathy with full house pattern in immunofluorescence and presence of tubular reticular inclusion in endothelial cell cytoplasm in electron microscopy. So the final diagnosis we kept was systemic lupus erythematosus, having presented with nephrotic syndrome caused by lupus nephritis class 5, that is pure membranous involvement in lupus nephritis, along with sensorimotor axonal peripheral neuropathy with chronic active colitis, both secondary to lupus. Patient was treated with pulse methylprednisolone followed by oral prednisolone. Patient was also started on a low dose IV cyclophosphamide therapy, that is 500 mg every 15 days for management of lupus membranous, and antiproteinuric measures was also given. Patient responded well to the therapy. On follow-up at 2 months, her edema resolved with fall in 24 urinary protein exclusion to non-nephrotic range. Her GI complaints also resolved. Improvement was seen in neurological involvement. Power at hip, knee, and elbow improved to normal, but residual distal weakness was persistent at ankle and wrist joint. The last time the patient presented in 15th January. The renal, coming to the discussion part, renal involvement in SLE ranges from asymptomatic urinary abnormality to rapidly progressive glomerulonephritis. Around 40% of SLE patients develop clinically evident renal involvement, either as initial presentation or later in the course of the disease, but mostly within the first 5 years of the diagnosis. GI involvement, as seen in our patient, is seen in around 30 to 50% of the patient, with diffuse abdominal pain being the most common complaint in GI lupus. Colon is the second most common site after ileum to have thickening more than 3 mm in a CT assessment based study in SLE patient with GI symptom. Coming to neuropathy part, the prevalence of neuropathy in lupus is seen in around 3 to 5% patient, and the most common type of peripheral neuropathy in SLE is sensorimotor axonal, presenting is distal painful neuropathy as seen in our patient. Coming to the part where we diagnose the case as lupus membranous nephritis can precede other clinical features of lupus. Lupus membranous nephritis can be considered even in the absence of autoantibodies if biopsy findings are consistent with lupus. Characteristic immunofluorescence finding of lupus in renal biopsy is full house pattern. A full house pattern is termed when there is positivity for 3 immunoglobulin and 2 complement pathway in immunofluorescence. In earlier days, full house nephropathy was used synonymously with lupus nephritis, and patient with full house nephropathy with negative autoantibody screen was termed as seronegative lupus. Along with the full house pattern, we also found tubular reticular inclusion in our patient, which is also fairly specific to diagnose lupus nephritis with a specificity of 80 to 96%. And it should also be noted that seroconversion from negative to positive lupus serology over years of follow-up has also been reported. This is a review article by Ponteselli published in 2021, states that proteinuria and abnormally urinary sediments can be the sole disease manifestation, and it can antedate, it can precede other clinical features and even immunological markers of the disease by years.
This is a study published in American Journal of American Society of Nephrology. They devised criteria. They devised criteria to diagnose lupus nephritis based on renal biopsy. They studied 300 patients of lupus nephritis. They devised 5 criteria that includes intense C1q staining, Pull-out staining, extraglomerular deposit, subendothelial and subepithelial deposit, and tubulo-reticular inclusion. Out of these 5, 3 criteria were fulfilling in our patient, that is full-out staining, tubulo-reticular inclusion, and there was extraglomerular deposits as demonstrated by patchy granular deposit of immunoglobulin and complement in immunofluorescence on tubular basement membrane. So a patient who is fulfilling 3 out of 5 criteria is found to have lupus with 95% of specificity. Here is the table from the same study, particularly directing at class 5 pure membranous lupus. With even 2 or more criteria from the above 5, if the patient fulfills 2 or more criteria, the specificity is up to 98%. And they found that if the patient is having 3 or more of the above 5 mentioned criteria, then the specificity is up to 100%. This is a study from SGPGI. They retrospectively studied 6,244 renal biopsy done over 11 years.
Sorry to interrupt here. I think you have already completed your presentation part, and discussion we can start further with input from other panelists also. So thank you. Now I am going to start the discussion part. I request Professor Siven Singh, sir, if you want to add something, then you can add. Then we'll start taking questions and taking feedback from other panelists.
Yeah, so this patient had diagnostic dilemma, which is still, I think, debatable diagnosis is there. First is membranous nephritis. It is secondary because PLAR is negative. So in secondary, most likely lupus, as already discussed, because the full house effect, reticuloendothelial inclusion bodies, extraglomerular deposits are suggestive of lupus, but this is not 100% diagnostic in view of 2019 EULAR criteria and ACR criteria. They say that ANA is must for diagnosis of lupus. And so the term seronegative lupus has been described earlier in literature and many case reports are there. But what will happen to this after 2019 EULAR criteria where ANA positivity is must? So in follow-up, this patient may develop, we'll follow this patient, and over a period of time, if she develops ANA positivity, then diagnosis will be clear. Otherwise, had to keep such patients in literature, it will, I think, it is a debatable topic with advent of 2019 EULAR criteria. Thank you.
Sir, if we take the SLIC criteria, I think there is no need of ANA or
Yeah.
just
Latest is EULAR ACR criteria. That's why I'm pointing this point. Now, whether seronegative lupus will be entity of future or not, it is debatable.
okay, but because the SLIC criteria has already taken this point, they have
SLIC
taken.
has taken, or earlier ACR has taken this point. It is okay. That is on that point, it is lupus. But the latest criteria, now it is debatable.
Okay. What was the titer value of anti-DS DNA in this patient? I think Rajidate can answer, sir.
Yeah.
Yes. Sir, the dsDNA found in our patient was, I think, done by ELISA method, and it was 62, and the normal range was up to less than 100, sir.
Okay. And the complement levels?
Complement levels were within normal limits, sir. Complement C3 was around 80, sir, and C4 was 17, sir.
Okay. Because when you presented this case, a reproductive age group female with multiple problems, abdominal pain, neuropathy manifestation, nephropathy manifestation. So when I was asking that what will be the most probable cause, I was looking for SLE. I was thinking that it can be a disease in which involve multiple systems. So, but you have kept amyloidosis as a cause and other things. very rare causes as a differential diagnosis. Okay, let's start taking inputs from Professor Deepika Joshi, ma'am. Ma'am, you can unmute and give your comments.
Yeah, Abhishek, no, my submission, had this been only a nephrology case, then the differentials are all right. But once with a neurological involvement, the DDs were very vague. I mean, porphyria can cause, I mean, there are a lot of differentials which you have to entertain. And in neurology, it is a traditional teaching that because if after having all the investigations, if you are telling the diagnosis, what is the big issue? You have not done anything. Even an MBBS student can tell that much. So at least with cases with neurological involvement, the DD should be discussed. At least we have an approach. Number two, SLE as such neuropathy is rare. And this is actually a non-length dependent neuropathy, because ट्रेडिशनली जो न्यूरोपैथी होती है डिस्टल सिमेट्रिकल पेरिफेरल, ये नॉन लेंथ डिपेंडेंट लाइक AIDP लाइक प्रेजेंटेशन, तो ये और भी रेयर है. तो आप रेयर चीज को आप पहले उसमें डाल रहे हो. एंड आई डोंट नो मतलब द डिफरेंशियल्स, क्योंकि रेजिडेंट्स तभी सीखेंगे जब आप उसमें स्टेप वाइज, जैसे पीडियाट्रिक्स डिपार्टमेंट ने बहुत अच्छे से टैबुलेट किया था.
Ma'am,
And very rare, and as you are right, but the other differentials should have been considered in this case, because it is predominantly a proximal followed by distal or a proximal involvement. So there are a variety of differentials which enter into this, and then we can search with renal involvement. So that is for the residents.
Yes, ma'am. What is your points that what should be the differential in this case?
Yeah, even a muscle disorder should be taken into account in this type of case. Then the other causes of SIDP, like whether it be the other inflammatory conditions, because amyloidosis presenting with a proximal neuropathy, I'm really not aware with this type of presentation and this type. Then the other causes of the non-length dependent, basically it is a GBS-like presentation where we are having a proximal more than distal. So the other differentials like the granulomatous conditions, other inflammatory conditions, drugs, toxins, even if it is not there, such conditions, botulism, like other conditions should be considered, which all come in the differential. Then the inflammatory muscle disorders, even if it could be secondary, they should be considered in this type of cases. In the differential at the history level, I'm saying, not after examination. The examination part, he told very nicely and they have done very nicely. That I totally agree. But I'm saying at the history level, because for SLE to present with this type of neuropathy is extremely rare, like they can, as far as I am aware. Thank you.
Okay, thank you, ma'am. I request Professor JP Ojha, sir. Yes, sir.
See, my comment is for the teaching point of view. My comment for the teaching point of view, this patient has a nephrotic syndrome presentation along with involuntary manifestation.
Ojha, sir, whenever you are speaking, there is some echo coming and we are not able to hear your voice clearly. There is some problem. Meanwhile, I request Dr. Pathak, you can unmute and give your comments.
Yeah, Madam rightly pointed it out. The problem is the nephrology people include urine RM as their part of as a part of their general examination, and the patient had SIDP like presentation and not GBS like presentation, right? And if you look at the ACR criteria, American College of Rheumatology, they've included acute presentations, acute CIDP or SIDP like presentation. They've not included in their definition. But this was nowhere near GBS-like presentation, and all the when the moment the nephrology people got 4+ in their urine, and with those abdominal complaints and periorbital swelling, they straight away jumped to they straight away had their differentials. What Madam is saying is when a neurology case is involved, when it's a pure neurology cases, the way we discuss is the differentials after history, differential after examination. If there would be no urine RM into the case, this would be technically SIDP, and there's a huge list of SIDP that should be discussed, right from vasculitic neuropathy to multiple myelomas to Castleman's to Poem syndrome. So there's a huge list coming up. But the problem is the way they presented their case, urine RM was their general examination, and the moment 4+ urine protein came up, the rest of the neurological diagnosis, the huge list took a backseat, and that was the problem. So, I mean, this was SIDP-like presentation going into the subacute phase, nowhere near GBS. And obviously, as I said, the proximal weakness slightly more than distal weakness. It had to be taken with a pinch of salt, completely NR, non-recordable NCVs, and 4+ protein, and then nephrology people had their differentials on board.
I think there is no harm in giving the differential after history.
Yeah.
That can be practiced here also, because this is a teaching platform. All the residents are connected also, so that will be a good practice. That after history you give the differential, then after examination you give the differential, even though it is from the Department of Nephrology. I request Dr. Devesh a quick comment from your side.
Am I audible?
Yes, you are audible.
A well presented case. I would comment that residents should meet the panelist or consultants 3-4 days before, not the day before the presentation. So I am not much aware of this case. So I will have no comment on this. Thank you.
Okay, so I think that comment you can give also in later on also. I was expecting the gastroenterology component, any input from your side? Like the patient.
Yes, the patient has presented with chronic pain abdomen, and there was thickening on CT angiography, and there were deep ulcers. That can be well explained by any vasculitic disease like SLE. And the differential would be here, if you find such ulcers, that will be also fit in inflammatory bowel disease like Crohn's disease. So there will be two differential for this fitting in this case, that will be IBD and that SLE. Both will respond to immunosuppression.
Okay, so thank you. I request Honorable Director, sir, sir, your comments on the presentation.
So again, presentation was good, but a lot of discussion on the differential diagnosis and still debating neurology versus nephrology versus gastroenterology, as all the organs was involved in this case, and such types of diseases as earlier known to cause involves all these organs, and overall discussion is good, and I think in this case, even after this meeting, the discussion will continue on this. Thank you very much.
So thank you, sir. I think there are many points which we can discuss, the management, the choice of drugs. There are other things also, but with the limited time we have to discuss the things. Thank you everyone for joining this meeting, and see you at the next Clinical Society meeting. I close the meeting.